Thank you. And at the outset, I would like to thank the organizer, Dr. Purvi Chawla and Dr. Manoj Chawla. And this is very important topic. Why? Because we were discussing, Dr. Partha and Dr. Bansi Sabu was debating on suboptimal type 1 diabetes care and suboptimal result in type 1. But though we have number of drugs available with us, now we are talking about diabetes remission with anti-obesity drug, and the scenario is still same, that most of our type 2 diabetic patients are also having suboptimal control. Only 15.7% are having good control of their diabetes. And not only diabetes under uncontrolled diabetes, but they are suffering with multiple comorbidities like hypertension, dyslipidemia, CKD, obesity, CVD, triple combination of type 2 diabetes, dyslipidemia, hypertension or obesity, and so on. And that's why we have to think something out of the box where we are coming across uncontrolled diabetic patient. But at the same time, what we have learned in our medicine for years together, that is Cushing syndrome, which is a severe endocrine disorder caused by chronic exposure of excess glucocorticoids, which can be exogenous or endogenous. Exogenous is very common because of unrestricted use of steroid by many a times for indication, without indication, just for pain by a non-allopathic practitioner, that is there. But when we are talking about endogenous Cushing syndrome, it is either ACTH dependent or ACTH independent, and we have to find out so on. But what is important, that in Cushing syndrome, they develop metabolic syndrome and they do develop insulin resistance, which later on leads to impaired glucose tolerance and occurrence of diabetes also. So prevalence of diabetes is almost 50% in Cushing syndrome patient. Now we have in 2016 another data that prevalence of hypercortisolism, not Cushing syndrome per se, but hypercortisolism in type 2 diabetic patient, and which was found to be 3.4%. Proper Cushing syndrome was also there, that Cushing syndrome was almost 1.4%, but hypercortisolism was 3.4%. And then came a very thought-provoking study, that is catalytic study, which is the primary report. Still study is going on for effect of mifepristone on this, but we have data of the first half of the study that 24% of type 2 diabetic patients who are uncontrolled on 2 or more medications having disorder cortisol, which was previously thought to be 3.4% and 10%, and most of the time less than 10%. Here they have taken comprehensive assessment by lab and adrenal imaging also. Dexamethasone suppression test was also done. Exclusion was also done depending on the previous exposure to steroid. Screening was done by 1 milligram dexamethasone suppression test, and here they have taken type 2 diabetic patient, adult from 18 to 80 years who are on multiple medicine and not yet under control, and what they found that older age significantly increases hypercortisolism. BMI below 30 is independently associated with high odds of hypercortisolism. SGLT2 and GLP-1 were more prevalently used in patients with hypercortisolism, and ethnicity and multiple medication including fibrates and analgesic also increases odds to hypercortisolism. Along with that, we have data that patients with Cushing syndrome, patients with subclinical Cushing syndrome also develop cardiovascular risk. They have more risk for cardiovascular event in comparison to non-Cushing syndrome. Another data were adrenalectomy, which also improves blood pressure and overall metabolic control in patients with subclinical or clinical Cushing syndrome, also improves HbA1c. So we have data now with us that hypercortisolism affects type 2 diabetes occurrence, especially difficult to treat type 2 diabetic patient, and if we find out the cause, if we treat the cause, it may be helpful. So in context of uncontrolled diabetes, hypercortisolism, we have to think in three ways. It can be a comorbidity. As by previous speaker, Dr. Amit was describing that mental health is also very important. Sometimes mental health is also causing. This may be a comorbidity, or this can be a consequence because of multiple metabolic imbalance. This may be part of that metabolic imbalance, or sometimes it can be a cause. So that is what you have to understand. The ominous octet, what Dr. DiFranco has taught us years back, which also having, 7 out of 8 part is affected by hypercortisolism also. Muscle, alpha cell, beta cell, brain, liver, fat cell and gut. So except kidney and that renal glycosuria, all are affected by hypercortisolism. So when to suspect hypercortisolism? When you feel the patient with signs of facial plethora, proximal myopathy, cutaneous stria, bruces, central adiposity, especially the buffalo hump, supraclavicular fullness, acne, hirsutism, paper thin skin, you may have to think for Cushing syndrome. But these are the patient where you will suspect Cushing syndrome. So in routine type 2 diabetic patient coming to our own clinic, where to suspect and how to screen? Screening is very simple. It is standardized that 1 milligram of dexamethasone suppression test overnight is the best test for screening. Then you can go for late night salivary cortisol or 24-hour unfractionated cortisol. So because there is no single test which will help us to prove Cushing syndrome or hypercortisolism, so you may have to repeat the test. You may have to have at least 2 or 3 tests available with us to diagnose Cushing syndrome or hypercortisolism. But the screening test is dexamethasone suppression test. And if you find out something, then you have to see either it is pituitary or adrenal, and accordingly we may have to go for further imaging and localizing the lesion. That which population you would like to screen for hypercortisolism, difficult to treat diabetes, as we are already discussing, but along with that, patient with resistant hypertension and patient with accidentaloma, or we can say incidentaloma, that we come across adrenal adenoma on routine imaging, either USG or CT scan, you have to analyze patient for hypercortisolism. So this is very important. These are another data which are published in 2021, that patient with type 2 diabetes who are uncontrolled on multiple medicine, 3 to 3.5 times higher chances of having hypercortisolism. You may have to go for plasma ACTH, pituitary MRI, high dose dexamethasone suppression whenever it is indicated. Localizing from inferior petrosal sinus sampling is also very important to localize the lesion, and adrenal localizing procedure may be required in form of MRI. Along with that, it is not a cakewalk. We were discussing type 1 management in India is also not a cakewalk, but Cushing syndrome diagnosis or hypercortisolism diagnosis is also not a cakewalk, because physical stress can cause hypercortisolemia. Mental stress like hospitalization, drugs, alcohol abuse, withdrawal, chronic depression, panic disorder may also give rise to higher cortisol level and metabolic abnormalities. So never rely on single cortisol level, and whenever you suspect, go for dexamethasone suppression test, because single cortisol is not going to give you value anyway because of these multiple things. False negative test with dexamethasone suppression test is possible with chronic renal failure and hypometabolism because of liver failure, and false positive test can be due to obesity, stress, alcoholism and psychiatric illness. So if you have some doubtfulness as far as 1 milligram of dexamethasone suppression, always do different kind of tests like 24 hours urinary cortisol or late night salivary cortisol, because you may need different kind of testing to prove if patient is having hypercortisolism. Now we are discussing this therapy, but do we have, discussing hypercortisolism, but do we have therapy to treat such type of hypercortisolism? We are lacking a very good agent as far as pharmacological agent is concerned. So best thing is like what we do in routine Cushing syndrome patient, that if you find out the lesion, if you localize the lesion, then surgical treatment is the best choice. Followed by maybe radiotherapy is there. As far as medication is concerned, from diabetic point of view, because it acts on alpha cell and hyperglucagonemia, GLP-1 therapy, DPP-1 therapy, and because SGLT2 is not affected by hypercortisolism, these are the better agent to control diabetes. But on the other side, we have paclitaxel for pituitary directed agent, if that is pituitary Cushing syndrome, or adrenal directed agent like levoketoconazole, osildrastate, metadopan, or GR directed agent, that is receptor related agent, that is called mifepristone. And cabergoline reduces insulin resistance, reduces gluconeogenesis. If you remember, bromocriptine was once launched as an anti-diabetic medicine in a quick release formula, though it never get popularized, but cabergoline on similar pathway, having similar better action on insulin resistance. Paclitaxel actually worsen insulin resistance and causes diabetes. So paclitaxel is to treat Cushing syndrome, not to treat our difficult type 2 diabetes. So just leave it alone. And why all this, why I am talking this topic today, is a buzz created by this catalyst report, and the mifepristone is the drug which is going to be already undergoing a clinical trial if it is helping our patient or not, because it reduces insulin resistance. But mifepristone, until unless we have data of this catalyst study, this is something we need FDA approval. It is not a very easy and simple drug like just to use SGLT2 fungal infection हुआ बंद कर दिया वापस या no. It may cause hemodynamic stability, it may cause adrenal insufficiency. So if you are just thinking after my talk that all my uncontrolled diabetic patients should be on mifepristone, no. This is not the time. This is just an indication which may open a new horizon to treat our uncontrolled type 2 diabetic patients. So just to summarize, almost a quarter of patients with type 2 diabetes require 3 or more medication, and though they are remaining not in exactly under control, elevated cortisol activity can exacerbate the pathophysiology of type 2 diabetes and can counter the effect of traditional anti-diabetic medication, making diabetes control challenging. Studies emerging over the last 2 decades suggesting 10% and above patients with uncontrolled type 2 diabetes do have some or more hypercortisolism. Patient treatment resistant with type 2 diabetes should therefore be evaluated for hypercortisolism at least, and maybe this will be one of such future where we may apply such type of agent or surgery for our uncontrolled type 2 diabetic patient. Thank you.